Excellent. We are now live on Facebook.
Good to meet everybody, and thank you for spending some time with us this evening.
We will be starting in just a few minutes, okay? We're just getting everything up and running, so we are ready for tonight. We thought we would start off with something a little funny, so let you kind of read through that a little bit while you are getting things organized. There we go. All right, so Dr. Jim, it's nice to be here.
And here as well.
So we thought we'd start off with something a little funny because there really isn't anything funny about halitosis, which I know. Tonight we're going to be discussing all things halitosis and the dynamic duo of myself and good old Dr. Hyland.
Dr. Jim, Dr. Hygienist, Kerry and I have worked together for 20 years now, and we've been doing this type of care for about 15 years. It's changed the way I practice dentistry, and it's applicable to perio, to breath, to periimplantitis. So we'll share this information with you today. New information. We are sharing a 4-hour presentation in about 30 minutes. So we're hitting the highlights. You kind of have to trust us that we're going over things, but later on you can please, they should chat in between, ask questions. We'll have some questions at the end, and we'll give you our email addresses, and certainly you're welcome to contact us there or through the IDL group on Facebook. And thanks to this group for offering us the opportunity to share this type of information with you. I think you'll find it useful. I love the group. We get a great group of people, accepting of everybody. And with that, let's get going.
Sure. So Dr. Jim and I work in a general practice in Canada, so you might pick up a little bit of our accent as we are speaking. And I also I'm obviously a dental hygienist, and I work in ortho. I work in general. I'm an author. You know, a lot of different things that we get to do.
Well, both of us work for Orovital, so we have a conflict of interest. Want to disclose that to you. Our purpose is not to promote Orovital, but to talk to you about the concepts of care that are applicable in general. And so I hope that we do a good job of doing that.
So we thought we'd start off the evening by just sort of asking, in a way, you know, have you ever taken a seminar that really just focused on malodor? Well, I don't know about you, Dr. Hyland, but when I was in school, we had maybe one paragraph of information. Now, that was 20 years ago. So the good news is things are starting to shift and change. However, I don't think they've changed that much. So tonight should be a wealth of information for yourself if you're suffering, for some of your clients, if they haven't really asked you or had that conversation with. We hope that will give you some nuggets you can take away.
The information we're sharing, we learned from Ann Bosey. She took a master's degree in research in what causes breath odor, where do the bacteria, what type of bacteria, which treatments. And we were actually the first people she taught how to do that in 2007. And from that has come the presentation we're doing tonight. So these questions, let's just talk about the things that you might be thinking about. You know, what factors do you think cause breath odor? What do you think a patient's perio looks like that has breath odor? Do you treat breath odor? Are you comfortable with it? Do you diagnose it? Can you determine if you're successful or not? How comfortable are you talking about or engaging with it, you or the team? So explore these questions yourself now and listen to what we have to say. And let's go back and look at the end of the session and say, you know, where am I? What did we learn new tonight?
Good idea. So I want to first start talking about the halitosis patient, the breath patient, the malodor patient or client. They really are walking a tightrope in their life. They are totally consumed usually with their bad breath, and they're just not sure what's going to set it off. So they are very particular. They've got a lot of neurotic things, which Dr. Hyland will discuss in a little bit. And it doesn't take much for them to kind of break the rope, for things to kind of fall apart. And that's usually when I meet these clients, is that they have exhausted all resources that they possibly know of. And they're coming to me to say, hey, Kerry, can you help me? I don't know what to do. And so when I'm dealing with these types of patients or clients, I want to make sure that I'm not only playing chess, but I am winning. I want to get checkmate. I want to ensure that things work out properly. And I want to make sure at the end that they can have the breath or the kiss of confidence. I want them to be able to reach outside their social circles and not be constantly paranoid about it.
So when we look at a breath patient, we look at their teeth, we pick up a mirror, we examine their mouth. What are some things that we need to understand before we see the patient? What's the new information we'd like to share? Well, 90% of patients' breath odor comes from the mouth. It does not come from the stomach. And that's very important for you to understand. They always assume it's the, I don't know, the sinuses, the lungs, the stomach coming from the nasal passages. They are causes, but they are remote and rare. It really is breath odor. The other thing is that the same bacteria that cause gum disease cause breath odor, and they cause periimplantitis. So if you've been successful in treating breath odor, you can be successful in these other areas as well. And all you need to do to treat them is kill the pathogens that are causing the problem, the same way a physician would kill ear, chest, or bladder infections, but they do it predictably. We'll teach you how to do that, and you have to use new methods of biofilm control. I don't like the word oral hygiene. It's biofilm control that really counts. The odors are produced by the breakdown of protein. So if they have a high protein diet, that might be something contributing to odors, but when they break down, it forms the volatile sulfur compounds, the foul smells that you pick up. You can have this happening in healthy mouths, and that's what's going to be profound. I mean, the patients that come to see us, they have no bleeding. They floss 6-7 times a day. Kids come and see us and they have breath odor. Patients with dentures come to see us. So when these patients are seeing you, it's not a periodontal issue. It maybe is on the back of the tongue, the throat, the tonsils, and the bacteria, instead of producing disease, simply produce odors. But the key is, if you can't control those pathogens on the back of the tongue, throat, and tonsils, you can't control periodontal disease or breath odor because the patients reinfect themselves. So you've got to offer this type of treatment to your existing patients. You can offer it to new patients. You can market for this. There's a market out there. People aren't doing it. Patients will pay big dollars for this. Look at who's going to be treating it. It's going to be your team that's treating it for the most part. I mean, Kerry does most of the treatment. The dental assistants can do it, hygienists. It's a good revenue source, and you're helping people that need help. So there's some new information for you about breath odor.
So with that being said, when we first started down this journey 15 years ago, basically, I really didn't know what questions to ask. I didn't know how to start that conversation. And I was actually slightly petrified. I don't know about you, but if a patient asked me and I was like, maybe Listerine, maybe this, I don't know, come and see me more frequently, I didn't know how to handle it. And I also didn't know how to bring up that conversation with my patient to say, hey, I'm concerned, I'm detecting an odor. And I also wanted to ensure and look at a bit more the medical history, because that seems to be where everybody blames. They think, oh, it's got to be their health history. They must have something going on there. And like Dr. Howland said, 90 to 95% of breath odors actually originates from the oral environment.
And Kerry, the patients tend to get blamed for this problem. But often when you get healthy mouths, it's not their fault. It's just we don't know where it's coming from. So we refer them elsewhere, and it's our responsibility. We'll show you that tonight.
So these are some questions that you can totally add to your health history questionnaire, or just in conversation if someone sort of hints or mentions that they have halitosis. I want to understand the significance of it. Is it something that just is like episodic where it comes and goes, it bothers them a few times a week or once a month, or is it something they're always worrying about? Obviously, the more significant of an answer, the more significant of the treatment or how much of the conversation we're going to have. How frequently does the bad taste last in their mouth? Is it coming and going? Is it there all the time? What kind of bad taste is it? Is it affecting their work and their social life? And we've had some really unfortunate stories to listen to myself about different patients not going for promotions and not having interpersonal relationships because they were so worried that they were going to share their bad breath with other people. So it definitely often affects their confidence. And a good question on the health history is, would you like fresher breath? That opens the door, and then you can ask them all these other leading questions to find out what significance that is. Also, I want to understand that client, that patient a bit more. I want to dive further into their health history and their medical dental history. I want to know, does someone else in their family have this?
Why do you want to know that, Kerry?
Because often they're transferred. So any children can blame their parents usually, and their parents can blame their parents. And nobody has to take responsibility for it. Okay, we're going to blame somebody else. How's
Okay.
that?
So it's transferred the bacteria through kissing for the most part, and it's both among themselves and, quite frankly, with their pets as well. Yeah.
So often I want to then look at their health history. I also want to ask them about their mouth to see, does their mouth feel dry? A lot of these patients will say yes, but when we get in there and there's so much saliva, it's really about the bacteria and how it's interacting that's leading to the dry mouth feeling. Okay. I also am going to ask them about compulsive mints, gums, and mouthwashes. Why? I want to know what they're using. Is it high in sugar? What's the pH level like? What other complications could come from excessive gum and mint use? The mouthwashes, I want to understand what mouthwashes they have used and what haven't worked so I can then offer an alternative solution. You've got to know the chemistry. You've got to look at the chemistry of what it is that they have been utilizing and what it is that you're going to potentially recommend. And of course, diet and nutrition. We need to ask them and talk to them about what they're eating, how often they're eating, and go from there.
With the meals, it's about the protein in particular and eating healthy and certainly being hydrated, because that's the way they prevent a dry mouth. They have to be well hydrated. So the patient that comes in to see us really is feeling like this, although they might be smiling. They're neurotic. They're terrified of what's happening to them. They're scared. They're socially withdrawn, poor self-image, compulsive use of mints, oral hygiene, significant stress in their life, and it rules and ruins their lives. So you need to be able to answer their questions about, why isn't my mouthwash working to control the breath odor? Are you just going to give me another mouthwash? You have to give a different type, and you have to explain when you can use mouthwashes and how it happens. You have to understand what their psychology is like so they feel comfortable and they'll follow the directions you give them. So patients are desperate for help. These are the things they tell us all the time. I saw my medical doctor. I saw my physician. They scoped me. They checked my stomach. They checked my sinuses. They said, go back and see the dentist. The dentist looks at it and says, I don't see a problem. They say, I've lost my sense of taste and smell. As Kerry said, my mouth feels pasty. And then you've got no bleeding on probing when you examine them. The pockets are 3 millimeters. No sign of periodontal disease. You're going like, these are perfect patients, but they have foul breath. You know, they floss, they brush, they rinse excessively. And they've been doing this before they come to see you. So by the time they come to see you, they've masked the breath odor. But by the end of the visit, the bacteria are multiplying again, and it starts all over, and they run into the car, and they're using the rinses, and then they're taking breaks every hour at work to keep themselves up on things, you know. Dental clinicians say, I'm healthy. They're frustrated. They're healthy, but they've got something happening. No one can find it. And finally, can you please help me? I'm nervous to talk about it. You need to tell them it's not their fault. We're not talking about patients with have 7 millimeter pockets, bridge calculus. These people are trying to do the best. They need our help.
And the excessiveness is actually kind of interesting. So when you actually are examining your patient, doing your assessment, you are going to see that these patients almost have no biofilm, very minimal bleeding, everything that way. They will be the ones with the major floss cuts and trauma from over flossing and over scraping their tongue. And those are sort of warning signs of what it is. And not all bad breath is the same. Sometimes we kind of group it all together, but there are different classifications of halitosis. There are patients that truly have halitosis, and these can be in forms of mild, moderate, and severe. Each one has its own challenge. Mild tends to have more of a taste component. Moderate will have bad taste and some odor. And severe patients, sometimes they don't even know they smell really bad, and they don't even know they have halitosis because the olfactory senses shut it off and say, that smells terrible, that tastes terrible. It's not going to be registered with their body anymore. Then there are the patients that maybe you have treated or someone else has treated, and they just can't let go of their halitosis. So now they're really in that halophobic component, and that circle and that rabbit wheel just keeps going round and round, hamster wheel, sorry, keeps going round and round and round.
Kerry, it's like that neurotic patient I talked about. You have to treat not only the breath, but you have to treat the person individually. You have to reassure them. And we have to develop methods that objectively determine, do they have breath odor and where is it? Record this, and then do the same tests afterwards and compare. You have to prove to them there is no breath odor. You can't trust them.
And the final group is trimethylmanuria, TMAU. Now, in my 20 years of dental hygiene, which is not as many as, Dr. Hyland's 46, but I've only ever come across one patient, and it was through a colleague who had trimethylmanuria. And trimethylmanuria will be something that sort of smells like urine. They can have excessive headaches, but it's a rare metabolic disorder, one that we can't treat, and not going to be your normal breath patient. So most of your patients that are suffering are either going to be halophobic type people or patients that have true halitosis.
So true or false? Severe halitosis can cause a loss of smell and a taste and a pasty, dry mouth. The answer is true. What happens is the volatile sulfur compounds are so intense, they overwhelm the taste buds, they get into the smell sensors, and they can't smell anymore, they can't taste. And the result of that is what we call a dry, pasty mouth. As Kerry even said, their mouths have lots of saliva, but they have this dry taste. So these are the things to listen for, clues that they have breath odor. Finally, breath odor, what is it? Well, volatile sulfur compounds, and the proteins metabolized in the cells. It produces mercaptans, dimethyl sulfide, hydrogen sulfide. And why do the bacteria produce this? Well, they produce it because when they do, it opens the cell wall junctions and allows the bacteria to penetrate. It assists with them being more pathogenic. So the smell really is about rotting flesh. And it's a sign that things are not good, and it has a metabolic impact as well.
And for most halitosis patients, as we've already said many times, instead of the bacteria going down, burrowing, creating tissue destruction, bone destruction, bleeding, it's coming up like a beautiful perfume. And so, not the nicest type of one to have or to suffer from. So when we want to offer treatment to patients, we need to identify the odor source. Okay, we need to look at the type, the location, and the amount of oral pathogens that are present. We want to reduce the load. We want to deal with other factors that contribute to breath odor for them. And some of those factors are the health history, the biofilm load and amount and composition. We want to know more about that. Their lifestyle, what's going on? How stressed out are they? What kinds of foods are they generally eating? How frequently are they eating? Their biofilm control and the frequency that they visit dental offices. Now, again, one of the things I'm going to stress to you is most of the clients that we start to treat in our practice were my 3-month appointments. Some of them actually chose, I had 2 patients in my lifetime, which is 2 more than what I ever want to have, that chose to smoke because they thought the smell of cigarette smoke smelled better than their halitosis. So these are some of the stories that I unpacked from some of my regular appointments that I had no idea that they were suffering from.
So how do we find out where the odor is coming from? This is the secret of doing an exam, and we can't smell it ourselves anymore. So you can use an oral chroma. That's the one on the top right, and you can use a halometer on the bottom. And the halometer tests for hydrogen sulfide. The oral chroma tests for the 3 gases. Now you have to figure out where the odor is coming from in the mouth. There are 3 areas: front of the tongue, back of the tongue, and between the teeth. So you're just going to take a mirror, rub it on the front of the tongue, blow it in the air, and put it on the patient's nose and ask them to smell their odors. They can't smell their breath, but if you wait for 10 or 15 seconds and wave it, they can. Note down how intense it is and where it's located. Then wipe it off, do the back of the throat, back in gag territory. Just touch, wave, and back out. 2 seconds. Rub it under the nose, record the smell. And then a long piece of floss. It's got to be non-mint, you keep reminding me. Because otherwise, they like to use minted floss, but you can't smell if it's minted floss. So you get a long piece of floss, you record between every single tooth, the amount of odor, is there odor or not, how strong is it? And you repeat that after treatment. That's how you can tell what's happening. That's an objective measurement of the problem, and you need the objective assessment. So how do you do some clinical tests now to figure out what's happening? Many of you heard me talk about the papillary bleeding score. In another series we're doing, I'll show a video of doing it. I'll go into it more. But soft picks are a stimulant for large spaces. You need firm pressure. Don't worry about firm pressure. You'll go from beer belly gums to 6-pack abs. That's why tissues shrink. They don't shrink from trauma. And you press it between the teeth first. You rub on the chin, rub on the inside the lip, on the labial tissues, ask if it hurts or bleeds. They say no. You say, well, then this can't cause bleeding. If your gums bleed, you have a gum disease, and you go between the teeth. When you do, and you see this bleeding, do it 2 or 3 times in different locations in the back. Get a mirror out. If you've got loops with a light, it's even better. And don't minimize the bleeding. When they're bleeding like this, you just ask them if they're kissable. Do they have gum disease? And when they do, now leads to, let's find out where the bacteria are. Let's do some disclosing. Maybe I've got to do periodontal charting. I have to measure the number of bleeding on probing points. I have to measure my pocket depths and things like that. And then you'll say to them, this amount of disease, I think I need to test for the pathogens that are there. Particularly for breath odor treatment, you need to know what's there, and you have to do a test. Kerry will review that later. So our goal then is to have no visible biofilm on disclosing, 0 bleeding when they use papillary in between. And our goal, we have to deliver 3 millimeter pockets, some 4s, and we have to teach them effective biofilm control. Those are the 2 components, as well as killing the pathogens that are causing the problem.
That's right. So a big part of what I do is I educate the patients about their home care, disclosing them, educating them that way, grabbing the interproximal brushes, soft pick, stimulants, TPA brushes, something along those lines, because we know that those brushes are better for our perio patients, right? They disrupt the biofilm, they disrupt and help to dislodge and remove it. Well, our halitosis patients are the same. They need that. The other thing is we want to focus on bleeding points, not just light, moderate, and not percentages. I want all halitosis patients to have less than 5 bleeding points in total. So the cool thing, if you are using Dentrex, they have a summary tab that it actually will total it all up for you. So in some of our experience of working with many offices across the country and across the nation, many times, as we know, perio charting is not done enough and not done completely. So I encourage you to do your charting, to do your recession, and to make sure you know where those hot spots are, because anywhere that's bleeding on a halitosis patient could be the source or could be the leading to discomfort or unwell feeling or unfresh feelings in their
The
mouth.
numbers are important. You have to compare again the before and after, and the patients have to see the change in the difference.
There are many companies out there now. I'm so excited actually that there are more, because DNA sampling of the oral environment, checking the oral pathogens is so important. We need to know the level, we need to know the risk, we need to know the load, and we also want to be able to check where and how we're sampling. So what we learned many years ago from Ann Bosey was it wasn't just the gram-negative anaerobes that we should be worrying about and measuring. We had to look at yeast. So when you're trying to choose your company to utilize sampling, take a look at the pathogen spread that they're looking at. Look at as well to see if they have a yeast option. Okay, some of them do, some of them it's an additional, some of them it's included. There are lots of choices out there.
Well, this is new information for most people, because, and we found out about it because when we were sampling originally, we did gram stain and we put a mirror on the tongue, put it on a slide, back of the tongue, put it in a slide, floss or soft pick and put samples on the slide. And what we found after treatments was that we had great difficulty changing the back of the tongue and the throat. And if we couldn't get at those bacteria, we couldn't get them healthy. And it was only when we discovered an antibiotic rinse, we were able to do that. And we saw the yeast in most of these patients.
So each test will present different ways. Reach out to the company that you want to know more information about, and they will help to explain the reports to you. So another part that I want to flag, another part I want to discuss and kind of dive further in is looking at their health history. Because again, we blame the patient as not brushing and not flossing and not cleaning properly, or it must be their health history. So acid reflux is a concern, but when it's active. If it's not active, you're not going to have any concerns or oral, you're not going to have the oral odor that comes from that. Postnasal drip is something that we chronically have to manage with the patient, find different solutions or alternatives, have that conversation. Same thing with sinusitis. I will dive a little deeper tonight into tonsil stones and tonsillitis, because that's its own group, and that there is a huge group of us, particularly dental professionals, I found from talking to people that really do suffer from this. Hernias, diabetes, dietary concerns can lead to breath odor, sleep and airway, different types of cancers can be detected in the oral environment, kidney disease, medications we know can lead it, and of course, smoking and alcohol. So most of these patients are not going to sort of check off a lot of these boxes. So when it comes to tonsillitis, it's definitely something we want to look for when we're screening our patients. I now really take the time to ensure I'm looking at those tonsils and I'm looking to see, are they class 1, 2? Where do they fit on that whole scale? And I want to see, can I see any tonsil stones? I want to ask them, do you suffer from these? Remember that these tonsillins are similar biofilm that contain filaments and cocci, and it's basically plaque food stuck in a dark, moist environment that produces pimple-like solution. And as people talk, as you're using all those muscles, they can pop out and they can be swallowed. They can come out on the tongue. They are really, really horrible things. They definitely are something that we want to, if someone suffers from one of these, we've got to get them to gargle the best they can at the back of their throat. And I found in my experience that often clients that suffer from tonsil stones need to have repetitive treatment because we as dental professionals can't take tonsils out. And depending on where you live in the state or the country that you live in, there are different rules as far as when ENTs will take them out. So something we can help patients manage. Having said that, there are a few things I want to know more about my patients, and it comes down to treatment. So what do we offer for treatment for tonsil stones? We want the patient to record and give us data on how frequently they're having them. How can I say if they got better or they got worse? Because patients that suffer from them, I had a little girl who was 8 years old and was getting 8 tonsillitis a day. And mom came back and said, Carrie, it's gotten better, but it's still there. And I'm thinking, okay, well, how often are you getting them? Oh, 1 to 2 a week. And I'm thinking 8 a day to 1 to 2 a week. I want to do cartwheels down the hall. I'm like, this is awesome. We have really improved her life. Let's retreat, let's retest. And we have slowly now have not seen her very often at all because things have been much more resolved.
This was one of our first patients we treated as a child. Funny story, her grandfather called me up. I went to dental school with him. He said, I can't help her. And he said, I heard you guys can do things. And what have we found out about dental professionals and breath odor care?
It's very high. It runs very high for most of us dental professionals, especially like I mentioned, the tonsillitis. And part of it's our exposure. We are exposed to these pathogenic aerosols all the time. And we don't think of our exposure rate, but that's a whole nother conversation, a whole nother course. So.
Who was your first patient that you treated, Karen?
You were.
And I didn't know I had a breath odor problem. And she said to me, Dad, now there's a solution. I'm going to tell you about it. You know? So there you are.
So with these patients, again, as I mentioned briefly, we want to take a test. And again, we not just want to check gram-negative anaerobes, we want to check for yeast. I want to encourage that client to gargle. And then usually what I'm recommending, depending on the age, the frequency, it might be an over-the-counter rinse, and Dr. Highland will chat about that in a few minutes, or sometimes it's an antibiotic antifungal rinse. I also want to ensure they're using like an oscillating, rotating brush so they can really disrupt that biofilm. Water flossers are awesome. And again, frequency. I want to see them more often so I can evaluate them long-term. So we want to make sure that the solutions we're offering, we're getting that 5-star review, right? We want to make sure that we're winning our cases. So we have to be detailed. And so again, we want to look at their health history. We want to make sure we have a full and complete periodontal exam. We want to look at their biofilm composition and load, their diet and hydration, their pH of their mouth. pH is huge, and there's a lot of great information that's coming in for that. And sometimes I can have an idea based on their pH in their mouth, what groups of bacteria might be growing in different areas, as we know. I want to assess their mouth for true dryness or dry feeling. I want to look at their oral hygiene by disclosing, reviewing all things interproximal brushes, rubber tips, sulfa brushes, anything to disrupt that biofilm and maneuver it. And different rinse products. Again, I need to know what they've tried in the past, look at that chemistry, and then modify it for the future.
So in therapy now, we need to do something different. We have to kill these pathogens. To kill the pathogens, you have to use an antibiotic. So the question is, how do you kill these pathogens? Because our study showed when we were originally doing this that you needed 6 to 8 weeks of oral antibiotics to work. And the question is, why don't oral antibiotics systemically delivered work? It's because they deliver at a low saliva level. And so for most periodontal disease and for all breath odor, you need high saliva levels. And the only way to get that is to deliver it in a rinse spit. It's a particulate antibiotic. It's going to contain metronidazole for the most part, nystatin for the yeast. It may contain amoxicillin if the test shows high levels of AA, or they have significant disease or widespread pathogens and very high levels. And they're going to rinse, gargle, and spit 3 times a day for 2 weeks. And the antibiotic delivered this way has no systemic effect, has a taste, it's a metallic taste, but you're not going to affect the gut bacteria and the medications they're taking. It's safer and more effective than oral delivered antibiotics. You should expect and will see with the system 80% reduction in bleeding and probing, and 80% of all pockets will shrink in the 2 weeks. So now you can introduce the over-the-counter rinses, because at that point you've changed the biofilm subgingivally up to 6 millimeters on the tongue, back of the throat, tonsils, and now the over-the-counter rinses, in a minute I'll go over them, that are targeting the gram-negative anaerobes can control the biofilms because they have fewer of them. It's not as thick. They can work. Okay, they aren't concentrated enough to change the biofilm, only to help to maintain it. So if we look at the rinses that we have now.
The other option for treatment we often add in is oral probiotics and sometimes the neti pot. Again, it's a different selection. We don't want to use the oral probiotics usually with the antibiotic rinses because they will counterintuitive, finish the antibiotic, and then start on the oral probiotics. And again, we have to ensure that the client sees dental professionals regularly.
So what's the chemistry like then? Basically, it's chlorine dioxide. That kills the gram-negative anaerobes. So you'll see that in closest. CDLX, a product I use as well, is neutral pH, and it has xylitol in it. Chlorine dioxide affects the mitochondria and its ability to break down protein. If they can't break the protein down, can't produce the odors, and the bacteria don't thrive because they're using up energy to metabolize, but they're not getting any back. SmartMouth does something a little different. They add zinc with the chlorine dioxide. The zinc coats the outside of the bacteria, stops the absorption of protein. So it is more effective, but for many people with a dry mouth, it leaves you with a dry mouth because it produces a salty and it's a stronger taste. So it really is a preference. People, you say, look, you have to buy this and this, see which one works better for you. It's individualized care. And then finally, you get into what many have been using, Scope, Listerine, things like that. These kill everything. You want to target gram-negative anaerobes. You don't want to be targeting the healthy bacteria in the mouth. So in summary, for perio, for breath, for peri-implantitis, these are the best over-the-counter rinses.
Yes, definitely look at that chemistry, see what worked. If someone tried Closest and that didn't work, think of another alternative that might be in the similar family, but often this is what's the best option. So kids has been a huge source of my treatment options. I see quite a few of them. It doesn't mean that every child needs the full work. Sometimes, kids, we have to look at those over-the-counter rinses. Closest, CDLX are great options because they are really flavor-free for kids. They're very palpable. I didn't realize that a lot of adults actually avoid rinses because they don't like the taste. They find them too strong, even as dental professionals. So these are some really great choices. There are many more out there. But for kids, if their parents say, oh my gosh, my little Sally, she wakes up and she's got this dragon breath, I want to sort of try starting with an over-the-counter rinse, disclose them, brush their tongue, review diet and frequency. So I don't know about you, but my children think when they were younger that goldfish or Cheez-Its are kind of like their own food group. Like they are one of those things that I don't understand why they love them so much, but they do. So
yeah,
I wanted to.
They don't understand that a different color isn't another food group either.
Yes, okay. No, the red one does not mean that they're eating beets, even though it may be covered with beet juice. It definitely is not. So look at the diet. See, some kids are so heavy in dairy that could be part of the problem as well. So we want to talk about interproximal cleaning. Unfortunately, for most kids, soft pick stimulants are not going to work. So it has to be the floss, maybe the expanding floss, the super floss, something that will really rub that interproximal area. And again, probiotics potentially, and increase frequency. If that doesn't work, or I deem that the severity of their concern is so significant, like that child that suffered from tonsils 8 times a day, I didn't just try that. I went to the full adult treatment where you do microbiological tests of their mouth. They are going to potentially use an antibiotic to rinse to help rebalance the bacteria, get them on a maintenance rinse to help manage it. It is ideal for children, if we can, to source potentially who's going to maybe reinfect them, who's that carrier. And so kind of putting the family through the sort of treatment and set up follow-up breath check appointments. Again, if that child is suffering from tonsillitis, I want to know more about frequency, how many times, what's causing it. Can they actually kind of extrude some of them on their own or not? So these are some of the highlights of halitosis treatment. And so I really think tonight, Jim, we have gone through a lot of things, and I've called you a lot of names, Dr. Hyland, Jim, what have you, as our relationship is very, unique and intertwined in many ways. But I think tonight we really have explored a lot of things. I hope that when you look at these questions, you have a few more answers.
Yeah. And again, we've given a 4-hour presentation in 30 minutes or 35 minutes. So we are open to the chat questions. And again, when we take a look at things, we say that there's a lot of people that used to have breath odor, the people that we take care of. And that's a nice thing to do. We improve people's lives. We have a variety in what we do during a day. And we've got a great marketing opportunity. We get about 2 new breath patients a month. So that's really nice. Again, a thank you to the I Love Dentistry community. Great to be sharing information with you. Hopefully what we've done is stimulated things.
Yeah.
And again, you can reach out to us now, Kerry.
Yep. You can reach out to us through Facebook, through the I Love Dentistry group, or here are our email addresses. I am Kerry Hyland Lepacek on Facebook, not just Kerry Lepacek on Facebook. I tried to drop Hyland so I could be my own independent person, but 20 years later, I'm still like his sidekick. Here we go. So we're excited as well. We're coming back for 2 more sessions. So please stay tuned in 2 weeks and then 2 weeks after that. If you're watching this on recording, don't worry. If you have questions from tonight, please do reach out to us. We would love to answer them. So we'll just stay here for a second in case there are any questions that come in. If not, thank you so much for watching. We hope that this has been inspiring, that you'll look at halitosis patients a bit differently, maybe think about adding a few things to your treatment options, because it really has inspired me to a new level that I really want to help patients. And if we can help you, help your patients, we have fun.
Were there any chat questions?
No, nothing has come in. So I think for tonight, we will call it.
Well, good night, and thank you for listening. We'll see you in 2 weeks.
Bye, everybody.
Bye-bye now.